Hello guys, welcome to our channel. Today we are going to discuss about the biochemistry and the rapid revision. In this, we are trying to cover the PYQs and the PYDs of the most important topics from the INICT, NEETPG and the FMG. So let's start our discussion with the biochemistry. The most important topic is the vitamins. So vitamins is subclassified into the fat-soluble vitamins and the water-soluble vitamins. So we all know that the fat-soluble vitamins are your vitamin K, vitamin E, vitamin D and vitamin A. Why these are the fat soluble? Because these are stored in the liver only. So how about your water soluble? That is your B and the C. We have the subclassifications like B1, B2, B3. All this will be subclassified. And there is no storage form for the water soluble vitamins. All right. And there is a toxicity. So high range of the toxicity is seen with the fat soluble and also deficiency is seen this. But in the water soluble, there is only deficiency that is associated with this vitamin B and C. No toxicity is seen in the water soluble because there is no storage itself. And next, moving on to the first one, our vitamin A deficiency. So we all know that the vitamin A deficiency is the most common cause, right? So the most common cause of the blindness in children, if the question is asking, so then you have to mark the vitamin A deficiency. How this is going to present it? Basically, this is going to present it as a xerophthalmia. So when the patient is having the xerophthalmia condition, so that is due to vitamin A deficiency. Basically, these symptoms will be presented. The first and foremost symptom that we will be seeing in this patient is the night blindness. So this is the commonly presented symptom by the patient itself. But when you screening, the first sign you are going to see is the white dot spot. So this is the white dot spot that you can see here. So on the conjunctiva, on the upper layer of the conjunctiva, this white dot spot is formed. So this is what happened in the patients with the xerophthalmia. And this classification is also commonly asked. The xerophthalmia 1A and the 1B is belongs to the reversible. Okay. So these all three cornea ulceration 1/3. So this all condition is the reversible only. If you treat early with the vitamin A, so then most likely the patient will be treated well. But after the xerophthalmia, third stage B, so this is completely irreversible. So high chance that the patient can having the irreversible blindness in the patient. So please do intervene immediately. How to intervene? What is the treatment that we are going to give this patient? So on the day 1, you have to give the vitamin A dosage, and day 2, you have to give the vitamin dosage, and day 14. So this is how you have to proceed for the vitamin A dosage in this patient. And what is the dosage of this vitamin A? So less than 6 months patient, you have to give the 50K international unit. If the patient is more than 6 months but 1 year, then we have to give the 1 lakh international units. And if the patient is more than 1 year, then we can go 1 year to 5 years. Then we can go for the 2 lakhs international units. So this is how we are going to proceed for the treatment for the patients of the vitamin A deficiency. And there is also one of the question is asked that the patient is 1 year, but the patient is having the 8 kgs only. And another patient scenario, 2 years, and this patient is also 8 kgs. As we discussed, the vitamin A is stored in the liver, right? So there is a high chance of the toxicity. So to avoid the toxicity, what we can do for this both scenarios also, we have to give the patients 1 lakh international units. So what is this condition? Here in the image, you can see this is the irreversible condition. Okay. So we cannot reverse this condition. This is known as the keratomalacia. Okay. This is the keratomalacia. Corneal ulcer is formed in the patients of the vitamin A deficiency. And this is also another symptoms that is commonly presented. This is commonly called as a follicular dermatitis or the pyrenoderma. So follicular dermatitis or the pyrenoderma, this is also seen in the vitamin A deficiency patients. And also those who are having the essential fatty acid deficiency also presented as this. So next discuss our next vitamin, that is your vitamin B3. How this vitamin B3 is known as, that is your niacin or nicotinamide. So this vitamin is very essential and commonly presented as a pellagra condition. What is this pellagra condition? What are the causes? Basically, when the patient dietary deficiency, such as patients those who are taking maize. So the maize eaters are commonly associated with the pellagra deficiency, or else those who are taking the sorghum as a diet. So sorghum will be having the multiple amino acids. So one of the amino acid, if the lysine is high, then the niacin will be decreased. For example, lysine is high, so the tryptophan will be decreased. So the sorghum eaters can also having the presentation with the pellagra. And other conditions like your carcinoid. So the carcinoid syndrome can also present it because this is under the tryptophan. And also heart nerve disease. Heart nerve disease is your genetic condition. Heart syndrome is also presented with this one. And also those who are taking the B6 deficiency. The consideration of this B6 deficiency is commonly associated with the TB drugs, especially your isoniazid. So this drug will be causing the B6 deficiency, and further the B6 will be decreasing your tryptophan. So if the tryptophan is decreased, this will cause the niacin deficiency. How these patients will be presented? Basically, these patients will be presented as a depresentation. What is this depresentation? Usually the diarrhea is a common symptom, and also patient will be having the dermatitis, and commonly these dermatitis lesions also seen on the sun exposed area. So this is also known as your photodermatitis. Here you can see this is the classic presentation of the Kaysal necklace. And also these patients will be having this sun exposed dermatitis that is seen in the pellagra. And the last one is the dementia. Why this dementia is occurring? Especially the dementia is due to the brain system, the cerebrum. The most of the cerebrum will be damaged due to niacin deficiency. That's why this is commonly seen in the alcoholics also. So the alcoholics also presenting this type of symptoms. If we does not treat this condition, this will lead to the death of the patient. So we have to treat the pellagra as much as early. And next one, that niacin is a used drug. So niacin is commonly used as a drug for the lipid disorders. So this is also your question. If the patient is having the high cholesterols, so if the patient is having the high cholesterol, then we can treat this patient with the drug of the choice is the niacin. All right. Next, moving on to our next classification, and next one is your B9 and the B12 deficiency. So how to classify the B9 and how to differentiate between the B12 patients. So these both will be causing the megaloblastic anemia. Okay, so both will be presenting with the megaloblastic anemia. This is also presenting with the megaloblastic anemia. So, but what are the causes will be presented? The most common cause will be alcohol only. Nowadays, the alcohol can cause in this patient as a deficiency, and other cause in the B12, specifically vegans, those who are not taking the non-veg. So the non-veg will be containing the B12. So if the non-veg is not taken by the patients, then specifically if they are vegan diet, this is will also cause the B12 deficiency. And how to differentiate between the B9 and B12. So if you order the labs, in the labs, the homocysteine, so the homocysteine levels is high, then we have to confirm that it could be B9 deficiency or the B12 deficiency, because in the labs of the B12 also, the homocysteine will be high. Then you can order on the another one, that is your methyl malonic acid. Okay, this methyl malonic acid will be normal in the B9, but same methyl malonic acid will be very high in the patients with the B12. So this is the main thing that can be present in the B12 deficiency patients. And what are the consequences of the B9 or the B12 deficiency? So the B9 deficiency will be leading to these conditions. What are these conditions? Neural tube defects. If the patient is possibly having the folate deficiency, then there is a high chance that the brain development or the spinal abnormalities is commonly seen with the pregnancy patients. So that's why you have to start the pregnancy patients on the folate. Okay, so the must and first thing that you have to follow, the folate is important for the neural development in the babies. And what are the other tests that can be done in these patients? That is the histidine, and another one is your FIGLU. So if the FIGLU is positive also, in the question if it is FIGLU positive, then also you can go for the folate deficiency. And for the homocysteine and methyl malonic acid, that is positive for the B12 deficiency. And another clue also, sometimes the examiner might be giving the another clue. This patient will be having the pernicious anemia. What is this pernicious anemia? Pernicious anemia is commonly seen in the post-gastro surgery, right? Intrinsic factor is absent. So then in the jejunal or this conditions, the gastric surgeries will happening now. So these patients will be presented as the pernicious anemia. And commonly, if the B12 deficiency is progressed, this can lead to the SCD. What is this SCD, guys? The subacute combined degeneration. What is this condition is due to B12 is the most important for your methylation, especially your DNA methylation. If the DNA is not producing properly, then there is a cause in the brain and the spinal cord, entire system will be disturbed, the neurons will be damaged, that will lead to the subacute combined degeneration. And this is the peripheral blood smear showing your megaloblast anemia. All right. So next, moving on to our next classification, that is your B1 deficiency. B1 is your thiamine. So thiamine is commonly mostly used for the multiple pathways of the carbohydrates, fats, and the metabolism. And at the same time, the thiamine will be commonly associated with the polished rice eaters. The patient who are eating the polished rice, then there is a high chance of the vitamin B deficiency, B1 deficiency. And how it is presented? Beriberi. The disease name itself, beriberi. And beriberi is subclassified. One is the wet beriberi and other one is the dry beriberi. So in the wet beriberi, how can you remember? So remember that your heart is always wet, right? With the full of circulation. The vena cavas and the aorta, everything will be always with the filled with the blood. So the wet beriberi will involve the heart and it can also cause the cardiomyopathy and the heart failure. So these patients, those who are involved with the wet beriberi, that will involve the heart. And dry beriberi will involve the neurons. So high risk of the CNS symptoms will be, and patients will be highly prone to strokes, and the patient will eventually peripheral paralysis will be seen and patient will be dead. And commonly, the polished rice is very back in those days, but nowadays the thiamine is classically presenting in the alcoholic patients. How in the alcoholic patients, when they are highly taking the thiamine, so this will lead to degeneration or the formation of this degeneration of the mammillary bodies is seen. Here you can see this is your mammillary bodies. Okay, this is your mammillary bodies. There is a specifically the degeneration or the necrosis seen in the mammillary bodies, and this will lead to the what kind of condition, guys? This is your commonly asked question, that is your Wernicke's encephalopathy. How this Wernicke's encephalopathy is presented? Remember with the mnemonic GOVA. Okay, global confusion and ophthalmoplegia and ataxia. So the jet abnormalities. If you doesn't read this condition, it will be followed by the Korsakoff syndrome. How this Korsakoff syndrome will be? The patient will be having the amnesia, both retrograde and the anterograde. And also the patient will be having the confabulation. How this confabulation will be contracted with the patient? Usually, if the episode is not remembered by the patient, so the patient doesn't strain himself to remember that episode. Instead of that, he will be creating his own thoughts and filling that particular episode. So that is what the confabulation. So how to treat this patient? Immediately, you have to give the thiamine. Okay. Always remember whether the patient in the question commonly asked whether we have to give the glucose first or we have to give the thiamine. So always you have to go for the thiamine only. So thiamine first, then only followed by your glucose. Why? Because the glycolysis pathway is mainly dependent on the thiamine. If there is a small amount of the thiamine that is also left in the glucose pathway, so then there is a high chance of the patient will be leading into the Wernicke's encephalopathy syndrome. So that's why firstly give the thiamine and then go for the glucose. All right. Next, and for the test, if you want to do the specific test, then you have to order for the trans ketolase test. Okay, so this is your trans ketolase test. And next, moving on to our B1. All right, so B1 is your riboflavin. The riboflavin is commonly presented as a glossitis. The patient will be having the inflammation on the tongue and also chiliosis. See, there is a specifically the crackles around the lips or the corners of the lips. This is presented in the riboflavin deficiency. And the itching and the burning of the eyes, this is due to corneal neovascularization. Okay, means neovascularization seen in the patients of the riboflavin deficiency. All right, this is how the patients will be presented. And there is a specific test that can be asked in your questions. Like, what is the test that will be done for the riboflavin? The test name is the erythrocyte glutathione reductase test. Okay, and for the transketolase for your B1, and the erythrocyte glutathione reductase for your B2. Sorry, that is for your riboflavin deficiency. Next, moving on to the B6. Okay, B6 also very famous one and very common one in the India. How this is common? Because of the, as I said before, this is due to your tubercular drugs. Okay, what is this B6? That is your pyridoxine, the only water soluble drug that will be having the both toxicity and plus that is also associated with the deficiency. All right, but let's understand how this the deficiency of the pyridoxine is seen. So the most common cause for is the TB drugs, and the specific drug that is causing it is the isoniazid, will be having the pyridoxine deficiency. And other conditions also, when the patient is having this condition specifically due to dietary, okay, dietary lack of the dietary, pyridoxine also can cause. And the pyridoxine is very important in specific transformations in the enzyme pathways like transamination. Okay, this is important for the transamination of the amino acids, and also this is important for your heme synthesis, and this is also important for the non-oxidative decarboxylation. Next, how this will be presented? The peripheral neuropathy is the classic presentation of the patients, those who are suffering from the pyridoxine deficiency. Okay, this is how this condition will be presented. Next, moving on to the vitamin D. Before we understand the vitamin D, let's see how the vitamin D is synthesized in our body. So most of the vitamin D will be coming from your UV rays only. From the sunlight, we will be getting through the epidermal layer exposure, and this epidermis will be releasing the 7-dehydrocholesterol. So then this 7-dehydrocholesterol will reach into our liver region, and liver will be converting it into the 25-hydrovitamin D3. So after that, it will be reaching into your kidneys, especially in the PCT, and PCT will be converting it into the biologically active, the 125 dihydroxy vitamin D3. So this is our vitamin D active role, and how this is also known as your calcitriol. So this is the common pathway of the vitamin D. But the patients, those who are suffering from the vitamin D deficiency, what is the common presentation, guys? That is your rickets in the children and osteomalacia in the elderly people, right? So how the rickets is presented in this patient? So here you can see the rickets will be classically presented in the children as the decreased fragileness. Okay, this will be decreased fragileness. Why? Because of the decreased mineralization. If there is no vitamin D, there is no mineralization will be presented in this patient. So what we can do in this patient, we have to treat with the straws therapy. Okay, straws therapy that is specifically used for the vitamin D deficiency. Okay, what we are going to do, we have to admit the vitamin D for the next 12 weeks. Okay, this is how we can treat this patient. What are the symptoms? The symptoms will be impaired growth and rachitic rosary. Patient will be having this genu valgum or the genu varus, and patient will be having the craniotapes decreased, delayed fontanelle closure. And when you see on the X-ray, this patient will be having this widening, growth plate widening, or the epiphysis widening will be seen, and also irregular fraying, like these kind of symptoms, classically cupping, slaying, and the fraying will be seen. So this is how it is presented. And there will be also commonly asked question about this one is the what is the lab values? So usually rickets is due to vitamin D deficiency. If the vitamin D is deficient, then there is a calcium deficiency also. If the calcium is deficient, your pathway PTH, the parathyroid hormone will be activated. If the parathyroid hormone, why it is activated? Because of the calcium is low. So it will further decrease the phosphate levels. So this is the classic picture of the labs in the rickets people. And rickets is the common cause. Rickets is the common cause for the genovirus and genovalgum, and also patient will be having the wind-shaft deformity. So these all three commonly present in the rickets babies. All right. Next, moving on to the inborn errors of metabolism. In the inborn errors of the metabolism, the first one is your alkoptonuria. So alkoptonuria is the first one is developed by the Garrod tetrad. The Garrod is a scientist who famously known for this discovery of the alkoptonuria. Why alkoptonuria is seen, guys? Because of the deficiency of the homogentasic acid. Okay, homogentasic oxidase. This is the deficiency due to alkoptonuria. And how these patients will be presented? This is also known as your black urine disease. And this black urine disease due to, for example, the patient is peed on this color, but due to the oxygen species, this will be converted over the 20 hours into the black urine. So this is how it is presented. And the onchronosis, okay? Onchronosis is seen in this patient, like black color discolorization or the deposits of this alkoptonuria seen in this patient. Especially your spinal region, the elbow region or the knee regions will be presented this condition. And also the sclera will be converting into the black color of the disease. So this is how the classically presented with the alkoptonuria patients. And the next one is your albinism. Albinism is commonly due to the deficiency of the tyrosinase. So the complete tyrosinase deficiency will be seen in this albinism patients. And this can involve the skin and also eyes. So this is what the albinism and their oculocutaneous subtypes will be presented. Deficiency of the tyrosinase. Next, moving on to our next disease, that is your phenylketonuria. So this is the common condition or the most common, let's say, worldwide. The patients, those who are suffering from the inborn errors of the metabolism. So the common condition is the phenylketonuria. Whereas the most common condition in India, that is your MECAD deficiency. The medium chain acid deficiency that is seen in the most commonly in the India. But in the worldwide, that is your phenylketonuria. How these patients will be presented? Basically, this is due to deficiency of the phenylalanine hydroxylase. Okay, so the phenylalanine hydroxylase will be deficient, so that the whatever the phenylalanine will be converted into the phenylactate, and also it will be converted into the phenyl acetate and phenyl pyruvate. So these three products, phenylactate, phenyl acetate, phenyl pyruvate, will be causing the mental retardation. The severe mental retardation is presented, and also limb spasticity. So the patient will be having the limb spasticity. And if the limb spasticity is due to tyrosine deficiency only. And further, the patient will be also having the melanin deficiency. These melanin deficiency will be reflected like this. So the patient will be having the gray hair. So the melanin deficiency is also seen in this patient. And what is the urine? Particularly the urine will be musty odor. Okay. So the musty odor urine is seen in these patients. This is all due to the other products due to deficiency of the phenyl hydrolase. So what is the test that we can perform in this patient? The test is the newborn screening. You can go for the newborn screening, the common program, universal program, or you can do the Guthrie test. Guthrie test we can do, and we can also do the ferric chloride test. These are the tests that we can perform in this patient. So the treatment is basically avoid the phenylalanine. So if you give the more and more phenylalanine, instead of converting to the other pathway, the phenylactate, acetate, pyruvate will be seen. basically to avoid the phenylalanine diet and also give the tyrosine diet. So the tyrosine will be converted into the other hormones, but not onto the phenylalanine. All right. So next, moving on to the next disease, that is your homocystinuria disease and the Marfan syndrome. So the difference between the Marfan syndrome and the homocystinuria. So let's understand this difference because it is easy to remember also. The Marfan syndrome is the most common autosomal dominant. Okay, this is the most common autosomal dominant. And the homocystinuria, this is the not most common, but this is your autosomal recessive disease. And the Marfan syndrome patients is due to FBN1. So the fibrillin gene, which is deficient in this patient. So the fibrillin gene is deficient in the Marfan syndrome. The hormone is not associated or the gene is not associated in the homocystinuria. Instead of that, the cystathine beta synthase. So the cystathine beta synthase is enzyme is deficient in the homocystinuria. So that's why this patient will be presented as a condition. So what are the symptoms? Both will be having the tall and both will be having the finger deformities. Okay, long slender fingers will be seen in these patients. Okay, and also patient will be having the skeletal deformities. And in the involvement of the heart, when the patients, those who are suffering from the Marfan syndrome, there will be classically presented as a mitral valve collapse. And also this patient will be presented as a aortic dissection. Remember, this aortic dissection is the most common cause of the death in the Marfan syndrome. Whereas the patients, those who are suffering from homocystinuria, they are more prone to the atherosclerosis. Okay, this inbuilt the homocysteine will be causing the atherosclerosis, early age, and also the premature strokes at before less than 30 years only, this patient will be having. And the mental retardation is not seen in the Marfan syndrome. So the patients, those who are suffering from the homocystinuria will be having the mental retardation. And there is a specific lens dislocation is seen in these both patients. So how can you remember? For example, the Marfan, right? So fan is always upwards. So the lens dislocation is also upward and temporal. And the homocystinuria. So urine will be downwards, right? So for that, you can remember like this, the lens dislocation of the homocystinuria is inferior and nasal. Okay, nasal. So this is how the difference between the Marfan and the homocystinuria. So the one last one, that is the nitroprusside. So the cyanide nitroprusside test is positive. Is positive in the patients those who are suffering from the homocystinuria, whereas your Marfan syndrome patients is the cyanide nitroprusside test is negative. All right. This is what the difference between the Marfan syndrome and the homocystinuria. And another one is your maple syrup urine disease. What is this maple syrup urine disease? This is due to deficiency of the branched chain keto acids deficiency. Okay, what are those branched chains, guys? Isoleucine and your leucine and valine. So these three are deficient in these patients. This will lead to the maple syrup urine disease. The smell of the urine will be sugary, like maple candy. This smell will be seen in this patient, and mental retardation is also seen in this patient. This is what the maple syrup urine disease. And next, we are also having the another classification, that is your tyrosinemias. So tyrosinemias is subdivided into the three types. So the first one is your tyrosinemia type 1, which is also known as your hepatorenal syndrome. Okay, the hepatorenal syndrome is your tyrosinemia 1. This is due to deficiency of the fumarate acetoacetate. Okay, the tyrosinemia 2. This is your classic type tyrosinemia, and in this patient, how they are going to present it? Basically, it will involve your oculocutaneous. Okay, both the skin and also the eyes. This is due to deficiency of the tyrosine transaminase. and your tyrosinemia is type 3. This is very rare and easily treatable. This will be your PHPP dioxygenase deficiency. Okay, this is the enzyme names that you can remember. This is the tyrosinemia status. And the classic picture here you can see the patient is having the lip biting self-mutilation and mental retardation and high uric acid levels. You might have already guessed this disease. This is your Lesch-Nyhan syndrome. What is this syndrome, guys? Lesch-Nyhan syndrome, and commonly asked question only in the past 2-3 papers. This question is came. So the Lesch-Nyhan disease is due to deficiency of the HGPRT enzyme. Okay, this is due to deficiency of the HGPRT enzyme. So common symptoms, as we discussed, same symptoms. The patient will be having the uric acid levels are very high, and this can lead to gout symptoms early in the childhood only. Self-mutilation is seen in this patient due to purine synthesis is problematic, and also patient will be presented with a mental retardation. Okay, these are the inborn errors that you have to must remember. And next, moving on to your classic pathways, and instead of the pathways, we can focus on the only the exam points. So we all know that oxidative phosphorylation have the different complexes. So end of the oxidative phosphorylation, the ATP production is our aim. So, but there are some competitive inhibitors. This will cause the complete pathway shutdown. So if there is a pathway, the suddenly some of the chemical, let's say some drug you have given. So this will block this pathway and will cause the complete shutdown of the ATP production. So what are those specific inhibitors at different levels of the complexes? Let's we understand. So your complex 1. So complex 1 is specifically inhibited by your biguanides. Okay. What are these biguanides? Can you recall? If the biguanides, you can recall, this is commonly with your sugar drugs, right? The diabetic drugs like metformin, other metformin type biguanides will be block of the oxidative phosphorylation complex 1. And also the other one is your rotenone. Okay, rotenone will also block. And also your barbiturates. Okay, barbiturates is also blocked. And pyridine. Okay, this is a fish poison. Pyridine it will also block. Next, moving on to the complex 2. Complex 2 is blocked due to your malonate. Okay, this can be due to malonate or the carboxyl. Carboxyl also your fish poison. Next, complex 3. So the complex 3 is due to blocked by the antimycin. Okay, antimycin, and also your BAL. BAL is an agent we give for the antidote purposes. So this can also block the complex 3. And the fourth one is very commonly asked question, guys. This is due to your cyanide. Okay, this can be blocked due to cyanide. This can be blocked due to your hydrogen sulfur, or this can also block due to your carbon monoxide. So carbon monoxide poison can also block the complex 4. Complex 5 is rarely blocked, but the block can be due to oligomycin. So this is what the different of the complexes and their particular inhibitors. Next, there are physiological uncouplers also. So these physiological uncouplers can also completely shut your oxidative decarboxylation. So what are these physiological uncouplers? The most common one is the thermogen. What are these thermogen? Like temperature increasing in our body. So thermogen is the most common one. So the second one is the thyroid. So high thyroid can also block this one. And next one is your lipids. Okay, high lipids can also damage the physiological uncoupler. And next, high bilirubin levels. Okay, high bilirubin levels. So the thyroid, thermogen, and the lipids, bilirubin is commonly associated. Next, understand the other classification, that is your glycosaminoglycans. So if these glycosaminoglycans are deficient, then the mucopolysaccharide diseases can be happened in this patient. So what are those glycosaminoglycans? The first one is your hyaluronic acid. So the hyaluronic acid is present in the synovial fluid, right? This is also present in the synovial fluid, and it is also present in the vitreous humor. So inside the eye, so the vitreous humor is present in the eye, right? So that is also present in the hyaluronic acid. And next one is your dermatan sulfate. So you must have already guessed the dermatan sulfate. So the derma name itself telling it is present in your skin. Okay, along with the skin, it is also present in the blood vessels, and also, yeah, all your blood vessels and epithelium, whatever the endothelium contains, like your glomerulus also, the basement membrane also contains the dermatin sulfate. Next, your keratin sulfate. Okay, so the keratin sulfate is present in the cornea. And the last one is your heparan sulfate. So the heparan sulfate is present in the basement membrane of the kidney. So difference between the dermatin sulfate, it is present in the endothelium, the fenestrated endothelium in the kidney glomerulus, that is your dermatin. But the specific basement membrane is the heparan sulfate. Okay, this is in your kidney's basement membrane. So this is what the glycosaminoglycans. Next one is your LDH. So the types of LDH that we can see here. So the LDH type 1. So this is present in the heart only. So basically here it is given the both heart and red blood cells, but it is more dominant in the heart only. And the LDH2 more dominant in the red blood cells. If these both are having the defect, for example, let's say the patient is having the MI. When you tested early, within the 24 hours, within the 24 hours, if you do the LDH, the LDH2 is positive. Okay. And the MI patients more than 24 hours, LDH1 will be positive. Why? Because of the LDH flip. Okay. Basically, your heart will be contents of the LDH1 only. If the LDH1 is damaged due to myocardial infarction, so this LDH1 will be leaking into the blood vessels. So that's why more than 24 hours, if you test, the LDH1 is the positive in the blood test. All right. Next, LDH3 is commonly seen in the lymph tissues, lungs, platelets, and the pancreas. And the LDH4 and the LDH5 is commonly present in the liver and the skeletal muscles. So this is also commonly and easy direct question can be asked in your examination. All right. So next one is your classification, guys. So we'll see the amino acid classification. Then we can go for the other disorders. So what is the amino acid classification that we have to remember here? So first thing, the amino acid classification can be due to structure and presenting of the other branched chains, or it is due to acidic type, basic type, aromatic rings, glucogen, ketogen, or the essential or the non-essential. How can you remember all? So first remember the structure of the amino acid. So it contains the carbon group and also it contains the ammonia groups. So this is how the basic amino acid structure. So in this, if you classify, the first one, the classification is the monoamine and monocarboxyl. So the examples for the monoamine monocarboxyl group is the common one, that is your glycine and the alanine. So glycine and alanine will belongs to the monoamine and monocarboxyl. The second one, the branched chains. We already discussed in the disease. The branched chain types are, what are those guys? That is your leucine, okay, isoleucine, and the valine. So this is the three branched chain types. And there some of the groups will be contained. For example, sulfur group is present. That is your cysteine. How can you remember? S for sulfur, S for S in the name. That is your cysteine. Next, the fourth one is the hydroxyl group. So the hydroxyl group present in the three types. That is your, how can you remember? Rho, Re, Re. So Rho, Re, Re. Your tyrosine and your serine, threonine. Okay. So Rho, Re, Re. So this can you remember, like hydroxyl groups is present in this amino acids. Next, the fifth type is your acidic types. Acidic types, the name itself end with the acidic only. Aspartic acid and also your glutamic acid. And also there are some of the basic types. And in the basic, your lysine, okay, arginine, and histidine. These are your basic types of the amino acids. And some of the amino acids will be containing the aromatic rings. Okay. Aromatic rings is present in the tryptophan and tyrosine. And histidine has a specific role. Histidine has a specific role. This will be work as a physiological buffer. Okay, this will work as a physiological buffer. If the pH is low, the histidine will be managed. If the pH is high, this can manage as a amino acid that can be managed with as a physiological buffer is the histidine. Okay, next, there are some amino acids complete glucogenic. Okay, these amino acids are only glucogenic. What are those? That is your alanine. And there are some amino acids completely ketogenic. This is your leucine. And remaining all are glucogenic and the ketogenic only. Next, essential amino acids. What are the essential amino acids? Here you can see the essential amino acids. There is a specific mnemonic for this, commonly used TV till 8 p.m. Okay, TV till 8 p.m. What is the examples for this, guys? T for threonine, and V for valine, and another tree for your tryptophan. Okay, I for isoleucine, both L's for your lysine and leucine, and P for phenylalanine, P for phenylalanine, and M for methionine. So TV till 8 p.m. is for the threonine, valine, tryptophan, isoleucine, leucine, lysine, and phenylalanine and the methionine. These are your essential. Remaining all your non-essential only. Next, moving on to the collagen type. So we have the 4 types of the collagen. So how can you remember the collagen? With the name of the SCAB mnemonic. What is the SCAB stands for? So type 1 is for the skeleton and also abundant your skin. And the C for cartilage, A for arteries, B for the basement membrane. And what are these if this collagen is deficient? We all know that the most abundant protein in the body is the your collagen only. And how the collagen synthesis is done by vitamin C, right? Vitamin C is the major one for the hydrolysis of the collagen production. And the type 1, if the type 1 is deficient, this can lead to the patients of the osteogenesis imperfecta. And how this is presented? With the joint hypermobility, dyscongenic, and also the bone disformation, especially in the tooth canals, and also blue sclera. So this is how the osteogenesis imperfecta type 1 is presented. And abundant in the skin, bone, tendons, dentines, fascia, all this. And the type 2 is present in the cartilage tissues. And the type 3 is present in your blood vessels. So that's why those who are suffering from the Ehlers-Danlos syndrome. How this Ehlers-Danlos syndrome? The skin fragility, the joint immobility, and also blood vessel deficiency, this patient will be presented. So this is your type 3 deficiency syndrome. And the 4th one, that is your basement membrane of the kidney, that these patients will be having the Alport syndrome symptoms. What is the Alport syndrome? It is a hereditary nephropathy. In this hereditary nephropathy, the patient will be classically SNHL and also ectopia lenses. Okay, ectopia lenses. And also this patient will be having the kidney problem, hereditary nephropathy. So this is what the Alport syndrome is presented. And some of the pathways and their key enzymes like rate limiting enzymes that you can remember. Your glycolysis rate limiting enzyme is the phosphofructokinase. Your TCA cycle is the isocitrate dehydrogenase is the rate limiting enzyme. And the HMP shunt, that is your glucose 6-phosphate dehydrogenase, which is your D6PD disease. If this is deficient, the patient will be having the hemolysis, intravascular hemolysis is presented, especially autosomal, X-linked dominant babies will be having this condition. And also, this is also commonly asked. The cholesterol synthesis is due to HMG-CoA reductase, and the ketogenesis is due to HMG-CoA synthase. Okay, the rate limiting enzymes also very commonly asked question. And the fatty acid oxidation, that is your carnitine, and the urea cycle is the carbamyl phosphate synthase. So okay, please go through this table once and remember the rate limiting enzymes. Next, moving on to the lysosome storage disorders. In the lysosome storage disorders, the common one is asked Tay-Sachs disease, Gaucher disease. And overall, the most common is the Gaucher disease, and the Tay-Sachs will be associated with the cherry red spot. So the cherry red spot is commonly seen in the Tay-Sachs disease only. And these patients will be having the onion skin appearance on the histology site. And what are the deficiency of the enzymes? So the Tay-Sachs is for the hexoamidase A. That is for your Tay-Sachs. Niemann-Pick disease, sphingomyelinase. Remember like knee and my. So Niemann-Pick disease is the sphingomyelinase. And sphingomyelinase will be having this lipin-laden macrophages. Here you can see the foam cells will be presented. This is for the Gaucher disease, sorry. So the foam cells will be presented on the histology of the sphingomyelinase deficiency of the Niemann-Pick disease. And these patients associated with the hepatosplenomegaly. Whereas your Tay-Sachs disease does not have the hepatosplenomegaly. And cherry red spot present in the other disease also, but most common is the Tay-Sachs only. Next, Gaucher disease is due to deficiency of the glucocerebrosidase, and the Krabbe disease, glucocerebrosidase, or the galactocerebrosidase disease. And the Fabry, that is only X-linked recessive of the lysosome storage disorders. And this is due to deficiency of the alpha galactosidase. And another thing that you can remember, the Gaucher disease. So the Gaucher disease will be having this one. So this is a classic presentation of the Gaucher disease. The tissue crumpled. So the tissue crumpled on the histology or the peripheral blood smear, that is associated with the Gaucher disease. Okay, just remember the enzyme name and the specific finding only. Okay, metachromatic leukodystrophy, very rarely seen, and this is due to aryl sulfatase enzyme deficiency. Next, Hunter and Hurler, we will be discussing these two separately later. And your glycogen storage disorders here. So the glycogen storage disorders, you can remember this like this. Von Wricke is the most common overall. And this patient will be having the severe hypoglycemia, big liver, like here in this picture, you can see this is all entire the hepatosplenomegaly of this patient. And other symptoms also this patient will be having. Lactic acidosis will be seen in this patient. So the lipids, high lipids is also seen in this patient. High uric acid is also very high. So doll-like faces. So the doll-like faces is also commonly seen with the von Wricke syndrome. The deficiency of the enzyme is the glucose 6-phosphatase. And the Pompe disease, this is the most severe one. Okay, most severe one, because the Pompe disease like pumping heart. So the big heart, pump heart, then you have to remember the Pompe disease. The only lysosomal storage disorder associated with the glycogen storage disorder, that is your Pompe disease. And next, Cory's disease, remember like this: C for Cory, D for debranching enzyme. Anderson, A for Anderson, B for branching enzyme. McArdle's for your muscle glycogen. And this patient, muscle cramps, teenage people, and also rhabdomyolysis and urine discoloration, all this will be associated with the McArdle's disease, most common in the adult patients. And H for Hirsch disease, that is associated with the liver glycogen phosphatase. This is what your glycogen storage disorders. Next, moving on to the hypercholesterolemia disorders. The type 1 and the type 2 is commonly as hyperchylomicronemia. This will be associated with the high triglycerides, and fraction will be elevated with the chylomicrons. And the hypercholesterolemia, this will be seen with the high level of the LDL and the cholesterol levels. So the name itself telling. So triglycerides high, chylomicrons is high, then that is what type 1 type of the hypercholesterolemia. And the type 2 will be hypercholesterolemia, only the LDL and the cholesterol will be high. And in this both, the most common one is the type 2 disease. All right. Next, moving on to the genetic disorders and their how to interpret. So the first one, autosomal dominant, this is the most common one, and this is the second most common. But due to consanguineous families, there is a high risk. Nowadays in India, the autosomal recessive also commonly found. How this is presented? So first thing is there is no skipping of the generation. If you see this life cycle now, this generation is affected, this generation is affected, this is also. So every generation will be affected, and incomplete penetrance and the variability of the expressivity. Whereas comparing to other one, here you can see this patient will be having the somewhere this patient will be related, so that will be causing the enzyme defects. And so in the basically all generations will be affected, but only the one generation will be having the severe condition. So autosomal recessive, this will be the carrier of the condition, but this will be the disease presentation. So this is how the autosomal recessive will be presented. And next one is your X-linked dominant. X-linked dominant is only transmitted from the father side. So X-linked recessive is only transmitted from the mother side. So this is how the X-linked dominant and the X-linked recessive. Only from the father to daughter, that is your X-linked dominant. From the mother to the son, that is your X-linked recessive. And yesterday we discussed mitochondrial inheritance, that is commonly from the mother to babies. Okay, mother to babies, that is your X-linked, that is your mitochondrial inheritance. Next, moving on to the last one, this is your mucopolysaccharide diseases. The common ones are your Hunter and the Hurler syndrome. What are the deficiency of their enzymes? So Hurler is associated with the alpha L hydrogenase deficiency, and Hunter is the sulfohydronate sulfatase deficiency. So these both are commonly asked, but last time there is a new question from the mucopolysaccharides. So for that we have included the Marquio and the Sanfilippo disease also. Just see the enzyme deficiencies and how they are presented. Basically, your Hurler syndrome will be having the patient the dermatan sulfate, and the Hunter syndrome will be dermatan and the heparin sulfate. The both will be present in the Hunter, whereas Hurler will be having the only dermatan sulfate. So this is what the difference between the Hunter and the Hurler diseases and their enzymes. All right. So this is what the entire biochemistry rapid revision class. So please do complete this revision and practice for the MCQs. Okay, this is a very, very good opportunity for you to do the rapid revision, because this is your scoring subject, guys. So don't forget to subscribe and share with your friends. And please do access to our new RR notes. This is the best notes that I can recommend for you. And please do subscribe to our YouTube channel. Soon we are going to update the expected topics and the rapid revision of the other subjects.